Thank you so much, Chairpersons. Thank you, Dr. GVK. After that wonderful oration, you know, talking about a similar thing, I think it's going to be, so please pardon me if I'm going away from the topic, but that was a wonderful oration about how triglycerides and how fat is played around in our body, and we are victims for it, and we are also people who advocate a lot of things, and probably we need to change a lot of stuff and a lot of learning from the oration. So I'm going to talk about tackling the Trinity, prioritizing treatment targets for type 2 diabetes. This is a Novo-sponsored talk. And I'm just setting the stage for Girish and Arun to actually talk about the newer therapies which have come in and whether pharmacotherapy is the treatment or what Sir told us about lifestyle is the treatment. But there's a lot of influence of cardiovascular disease, diabetes, and obesity. And we know that these metabolic abnormalities that we have in obesity and diabetes drives cardiovascular disease and chronic kidney disease globally. And it's a common soil hypothesis. So this is nothing new to this august audience, but most people with diabetes are obese. Most people with obesity have diabetes. When you have both these together, they are driving cardiovascular disease. We have close to 355 million people with obesity. We have around 100 million people with diabetes, 136 million with pre-diabetes. 355 million people with obesity is larger or higher than the whole population of the US. So we have patients who have diabetes and obesity together, and there's a whole overlap of risk factors. So whatever we spoke about, there's a whole overlap, and there seems to be a common link between all these things, whether it's diabetes, obesity, and cardiovascular risk. Even the pathophysiology of diabetes, obesity, and cardiovascular disease is very, very similar. And as Sir said, that today we have been fighting about what is the pathophysiology behind type 2 diabetes, and the ectopic deposition of fat in places where it should originally be, that's the subcute, and in the ectopic deposition in various organs, seems to be driving diabetes. And that's what the DIRECT study told us very, very well. And now after 6 years of the DIRECT, you have morphological evidence that if you are able to reduce the pancreatic fat, the functional capacity of the beta cell improves. So from 7 grams of fat when you're obese, and with a 10 to 15% weight loss, when that 7 grams comes down to 3 grams, your morphological changes in the pancreas makes the functional capacity of the pancreas better. So there's a lot of interlinking of pathophysiology of diabetes and obesity. All seems to be a inflammatory syndrome leading to all these procoagulant state and leading to cardiovascular disease. Now let us look at how can we shape these healthcare dynamics. We all know that even a 1 year of poor glycemic control in people with diabetes can cause a lot of increase in a lot of micro as well as macrovascular changes, as you can see. Every 1% increase in HbA1c lead to increased risk of cardiovascular complications. So whether it's heart failure, a peripheral disease, cardiovascular, and cardiovascular death. And as I said earlier, that obesity is a major determinant of increased cardiovascular disease. And those metabolic abnormalities are something which we have not been treating, whether it's blood pressure, blood glucose, insulin resistance, lipid, inflammation, all put together. Relationship between weight and cardiovascular disease has been there for pretty long. And during COVID times, especially the Coronado study, told us that obesity was one of the highest risk factors for adverse events following an hospitalization due to COVID, especially in the ICU. And that actually opened the eyes of a lot of people, because people expected a lot of people with other risk factors to die. But obesity is one of the highest risk factors, followed by hypertension and diabetes. So again, heart failure, obesity are all interlinked. And cardiovascular disease is the leading cause of disability and death for people with diabetes and obesity. So the figures are here, not getting into details of it. Can we treat it? That's most important. Can we treat all of them with pharmacotherapy, with lifestyle changes? And lifestyle changes needs to be the cornerstone of treatment. And we know that the UKPD is a very sincerely done study, actually left the answer unanswered when the trial ended, especially about macrovascular disease. The post-trial data follow-up, which came up in 2007, actually told us that patients who get controlled early have emergent risk reduction later on in life. Again, the metabolic memory that you need to treat them very aggressively earlier on in diabetes to get benefit over a period of time. The look ahead study and the benefits with weight loss again told us there's a 21% reduction in things that we are really concerned about. The macrovascular disease, the cardiovascular causes, non-fatal MI, non-fatal stroke, and admission for hospital for angina. Targeted weight loss seems to be one of our pathways in treating diabetes as well as obesity. And if you look at this closely, every percentage weight loss has got a significant reduction in comorbidity. Even a 3 to 5% weight loss can make changes in events, can make changes in comorbidity. And 10 to 15% weight loss is enough to cause a remission in diabetes, probably a partial remission in NAFLD. So this is what, whether we do it with a pharmacotherapy or lifestyle or bariatric surgery, we need to be targeting at least a 10% weight loss, which the ADA is recommending from 2023 onwards in people with diabetes. So multifactorial intervention has always been, and the Steno-2 study, and now we have almost more than 2 decades of follow-up of the Steno-2 study. Steno-2 was a very small study, but it looked at a multifactorial intervention. It looked at good glycemic control, it looked at weight management, therapeutic lifestyle changes, aspirin for platelet inhibition, statins for lipid control, and antihypertensives for blood pressure control, cessation of smoking. And they showed that there could be a 50% reduction in cardiovascular events if you have a multifactorial intervention. And even after 2 decades, we can see that there's a 45% reduction in mortality and at least a more than 8-year increase in survival, and almost a 33 to 48% reduction in microvascular complications. So multifactorial intervention, lifestyle, pharmacotherapy, all put together need to be practiced in our patients with diabetes to prevent the cardiovascular risk from progressing. So the ADA recommendations for adults with diabetes is very, very clear. Actually, we've been practicing very similar for a very, very long time, and we've been risk stratifying our patients for a very, very long time, and we have not been glucose-centric. The ADA came up much later on, but patients with high risk, patients with ASCVD, patients with at risk for chronic kidney disease, patients with risk for heart failure, patients with multiple risk factors need to be given either an SGLT2 or a GLP-1, irrespective of the HbA1c control. Patients with established ASCVD and with multiple risk factors may be even initiated on an SGLT2 or GLP-1 if the risk factors are high. Those are the recommendations from the ADA. Importantly, a multifactorial approach to reduction the risk of diabetes. So whether the foundations of diabetes management is glycemic management, lipid management, blood pressure, weight, and the agents which can reduce cardiovascular and kidney benefit. So addressing the trinity of cardiometabolic disease, you need to have a holistic, person-centered approach where lifestyle needs to change. We need to risk stratify patients, evaluation of diabetes, cardiovascular and kidney disease, weight management needs to come in, lipid, blood pressure, glycemic management needs to come in, and in a whole, that's the only way we can treat diabetes as such. And that's where the GLP-1 RAs probably comes with a role. They almost treat almost 5 of the 8 pathophysiological defects that we are looking at. So they treat majority of the components that we look at treating in people with diabetes and metabolic issues. So whether it's reduction in HbA1c, reduction in weight, reduction in blood pressure, some reduction in inflammatory markers, and they also have some cardiovascular benefit. So I'm just setting up the stage for our next speakers to take it forward. Thank you so much. Thank you for a patient hearing.